Hello, everyone. For those of you that were confused a second ago about the audio, I assure you, you don't have problems with your audio. There was no audio being shown. That was just some slides to give you an update on some things coming up. So hello, everyone. Welcome so much. Thank you for joining us for the third installment of LBDA's 2023 Community Webinar Series, Vision in Lewy Body Dementia. My name is Julia Wood, and I'm the Director of Professional and Community Education at the Lewy Body Dementia Association. Throughout the remainder of 2023, LBDA will be hosting a series of webinars on a variety of topics for people living with Lewy, their care partners, and community members. The topics have been selected based upon the needs identified in calls to our Lewy line, questions on our online Facebook groups, and in our support groups. Today's presentation will feature expert clinicians from LBDA's Research Center of Excellence at the University of Colorado. Before I introduce our first presenter, I would like to tell you a little bit about LBDA and LBDA's Research Center of Excellence program. The LBDA is a national nonprofit that was started by care partners 20 years ago who were seeking answers and support in their journey with Lewy body. Organization has grown to address and we're excited to say that we have received numerous applications to join the network and will be expanding in the program in 2024. So a few housekeeping items. You're welcome to submit your questions anytime with the Q&A button on the bottom of the screen. Following the presentations, our presenters will allow time to take questions for about 15 minutes. This presentation is being recorded, and a link to the recording will be made available about 1 week from today's event. Also, when you leave the webinar today, a brief survey will appear asking for your feedback about today's presentation. Please take a moment to complete the survey to help inform our content and educational events in the future. So with that, I would like to introduce our first presenter. Please welcome Dr. Samantha Holden, who is a movement disorder specialist neurologist at the University of Colorado. Welcome, Dr. Holden.
Thank you so much, Julia. I'm going to share our slides. Okay, well, welcome so much, everybody. We're so excited the day is finally here to share all this great information with you. I am Samantha Holden. I am both a movement disorders as well as a cognitive neurologist at the University of Colorado and the co-director of our Lewy Body Dementia Association Center of Excellence here. Here's an overview of our topics today, a lot to cover, and we're hoping to get through everything and have some time for questions with you all. My job today is to kind of set the stage in terms of clarification of some of the terminology. There's always confusion over the right words to use for the right conditions, even amongst medical professionals. So I'm just going to give a quick 10-minute overview of how we use these terms, what the definitions are, and what some of the overlap and differences are between some of the Lewy body conditions. So when we think about cognition or thinking and memory on the whole, we think about a spectrum from what we would consider normal or common, where as we age, certain things do slow down a little bit. Forgetfulness, forgetting what you went into the kitchen for, forgetting the name of that person, but it's not necessarily a predominant pattern of losses that are bothersome or affecting the person's day-to-day life. What pushes somebody over into what we would consider mild cognitive impairment is when there is more of a persistent pattern of trouble with thinking and memory. We can see it on our thinking and memory tests in the clinic, but the person's still fully independent, paying their bills, managing their medications, driving, shopping. It might take more energy and effort to do those things, but they can do it. What converts somebody to dementia is there is objective impairment on cognitive testing, and now the person is no longer independent because of it, starting with the complex things like bills and medications, but could progress to needing help with more basic things like getting dressed, bathing, or grooming. But dementia is a broad term. It's a category. It's not a specific condition. And there are many different underlying causes of any person's dementia, some of which come from the brain itself, and some of which are external stressors on the brain, things like medication side effects, thyroid disease, vitamin deficiencies. But when we think about the brain-caused forms of dementia, these are the big categories. And our focus with the LBDA and in our Center of Excellence at the University of Colorado are the Lewy body dementias, which account for up to a quarter of all the cases of people living with dementia. But when we use the Lewy body terms somewhat interchangeably, it can lead to a lot of confusion. When we talk about what Lewy bodies actually are, this is what we're talking about. So this is a microscopic picture of somebody's brain tissue after they've passed away on the right side there, where a special stain is applied to the brain tissue. And we can see the round little bubble inside this neuron here. And inside of that bubble is an abnormally folded and sticky protein called alpha-synuclein. The brain cells try to contain that abnormal protein, package it up, but then they can't get rid of it. And that bubble is stuck in the neurons, which leads to stress and then eventual death of those brain cells. But Lewy bodies are present in the brains of people with several different conditions. So the least precise term of a Lewy body disease means that under the microscope on autopsy, which is the only way for us to see the Lewy bodies right now, there are Lewy bodies in the brain cells. But depending on where they are, what part of the brain they're accumulating in, defines what the person looks like and the type of symptoms they have, which then leads us to put the specific type of condition label on them. So both Parkinson's and the Lewy body dementias are Lewy body diseases. There's Lewy bodies in the person's brain. But Lewy body dementia is still a category where people can either have Parkinson's disease that becomes dementia down the road, or it starts with more cognitive impairment and is then defined as dementia with Lewy bodies. The only difference between these two conditions right now, the definition being what came first and what is more bothersome and prominent, trouble moving the body or trouble with thinking and memory. And that's how we differentiate what's a Parkinson's disease dementia from what's dementia with Lewy bodies. When we're talking about Parkinson's disease dementia, any person that already has a diagnosis of Parkinson's disease, where they primarily have slowness of movement of their body with either a tremor at rest or rigidity and stiffness of their muscles, they have a very high risk in their lifetime of later developing dementia. About 80% of people living with Parkinson's will. And that risk is 4 to 6 times higher than for other people the same age without dementia. So every person already living with a diagnosis of Parkinson's disease needs to be carefully followed and screened for their thinking and memory throughout their disease course. And importantly, as we're going to focus on for today's webinar, the thinking and memory trouble that people with Parkinson's and with dementia with Lewy bodies have is different from what we see in people with Alzheimer's. It's less pure forgetfulness and memory loss or word finding difficulty, and more trouble with what we call executive functioning, planning, multitasking, following multiple steps, and making decisions, and visuospatial dysfunction that we're all going to be experts on by the end of today. As opposed to dementia with Lewy bodies, which is the thinking and memory problems first, and what leads the person to seek medical care. They may have some degree of trouble moving their body, slowness, stiffness, and shakiness, but they're coming to see the doctor because of their thinking and memory. To diagnose dementia with Lewy bodies, somebody must have dementia. There must be enough thinking and memory trouble that they're no longer independent. It has to be a decline from their previous baseline. And then we need 2 of these 4 core clinical features. The Parkinsonism, slowness, stiffness, shakiness, which we as the specialists might pick up even if the person's not noticing it, but some people don't have any Parkinsonism. Well-formed visual hallucinations, usually people or animals. REM sleep behavior disorder, which is the acting out of dreams that can happen years before anything else. And then the cognitive fluctuations, which are very dramatic ups and downs in the person's level of awareness, alertness, and attention. Sometimes can be confused even for seizure activity. But none of these 4 core features of Lewy body distinguish it from Parkinson's. The only difference is what comes first and what's more bothersome and prominent, trouble moving the body or trouble with thinking and memory. If we only have one of those core features of dementia with Lewy bodies, we will often order additional testing. Some of these tests can be difficult to obtain, and some aren't always covered by insurance, but working with your team of doctors to figure out what the most accurate diagnosis is, these tests can be helpful, but they also don't distinguish Parkinson's from Lewy body. As we kind of approach some of these symptoms today, and we think about the larger spectrum of the Lewy body diseases, from Parkinson's to Parkinson's disease dementia to dementia with Lewy bodies, all being in the same family of types of conditions, those motor symptoms, trouble moving the body, while they are often the first thing we think about when we think of Parkinsonian disorders, just really being mindful that there's so many other ways that the Parkinson's diseases can affect the entire body. And we're going to focus more on the visuospatial today, but all of these things can be overlapping and interweaving. Not everybody living with Parkinson's or Lewy body gets all these things, but just being aware of how these things can manifest helps us get people the right types of help. And the goal today is to make sure that everybody's aware of the visual symptoms that can happen so we can get people the right help. So as we go through today and as we come up with our questions, the reminder that Parkinson's disease dementia and dementia with Lewy bodies are both under this umbrella of Lewy body dementia and likely on a spectrum rather than 2 completely separate conditions. We cannot distinguish them from each other with any of these core features. It's the timing and the relative prominence, what came first and what was worst. And then we have to be aware of these things, both in the community as well as medical professionals, to get people the right help, to diagnose these things better, and then to hopefully cure them. So without further ado, I'd like to introduce one of my close collaborators here at the university, Dr. Victoria Pelak. Dr. Pelak is a very unique doctor in that she is both a neuro-ophthalmologist and understands how the eyes and the brain communicate with each other, and trying to separate out when it's an eye problem versus a brain problem. But she is also a board-certified behavioral neurologist in terms of a thinking and memory specialist. She's probably one of very, very few in the entire world that does that. And we're so lucky to have her here at the university. So Dr. Pelak, I'll turn the floor over to you.
Thank you. Thank you so much, Dr. Holden. My video is paused. I'll wait for the host to start my video, just so you know. I'm not hiding. And I will get started. Hopefully we'll get my video on pause so you can actually feel that you're talking to somebody. Okay, well, I thank you very much, Dr. Holden. I'm going to be speaking about Lewy body dementia and visual brain dysfunction. And to do so, I'm going to also be interweaving a description of my patient's story to help review these 4 topics. First, the brain's visual system. Next, Lewy body dementias in the visual brain. And then visual brain symptom recognition and assessment, as well as at the end, where you can learn more. All right, so I'm going to start, as I mentioned, with my patient, Mr. RS. And so you know, these are initials that I changed to protect privacy. And we eventually diagnosed Mr. RS with dementia with Lewy bodies. But during year 1 of his symptoms, prior to seeing us, he reported to his eye care providers the following. He said that he was having problems reading at work. In particular, he was having difficulty following what he was reading, especially when he was dealing with spreadsheets. And he was told he had normal eye examinations and that maybe new reading glasses will help. So he was giving new reading glasses, but this really did not change his symptoms and his ability to read. And he was also describing difficulty with driving, and this was making him extremely anxious. So he saw his primary care doctor, who did some cognitive screening, and he did actually quite well. On the test that he took, he scored 29 of 30 points. So he almost scored perfectly. So his primary care doctor decided to start him on Zoloft, 50 milligrams at night, and this really did help with his anxiety. So I want you to realize that what you just heard about Mr. RS was that he was actually reporting visual brain symptoms, not visual eye symptoms, but brain symptoms. And with his story kind of kept in your mind, and I'll go back over changes in his symptoms and what our findings were, but I want you to keep that in mind while we review the brain's visual system. So first, I'm just going to essentially start with the input. Of course, that's the eye, and 70% of all sensory receptors that come from all of our 5 senses, sometimes we now talk about 7 senses, just so you know, they come from the eye. So all the sensory input that our brain is receiving, 70% of that come from receptors that are in the eye. And the brain really must make room for this, of course, in order to process all of that visual sensory input. And it really does. It dedicates a lot of what you'll see, a lot of brain real estate to do that. So if we look at the brain's visual system, we're going to talk about 2 critical regions that really receive and process vision. First, we have regions that are exclusively dedicated to vision. And I'm just going to pause for a minute because I think I have somebody's mouse on my screen, and I just want to have that person remove their mouse so that we don't have some distraction there. Okay, thank you. So we have these critical regions, and critical region number 1, I'll call it, are regions that are exclusively dedicated to vision in the brain. And this makes up a full 25% of the brain. And second, we have regions that are within the brain's visual network, and this makes up another 25% of the brain. And these regions that I'm referring to as the visual network regions really interact directly with these dedicated visual regions to help us do several things, help us create visual memories, allow us to recognize people and objects and places, allow us to find our way. So visual spatial memory, it's important to have input into memory areas of our visual perceptions before we can even memorize places, and allow us to find our way even in new places and to avoid hazards. And then lastly, help us perform any complex visual task that we need to get through our day. So let's kind of move on to, instead of a pie chart representing representing our brain, let's take a look at an anatomical diagram of the brain so I can point out those critical regions I just referred to. So first are the regions we call those dedicated exclusively to vision. And this is in the very back part of the brain called the occipital lobe or occipital cortex that I have a large red star here. And the occipital cortex feeds information forward into the back part of an area called the parietal lobe and a back part of the area called the temporal lobe. So the posterior parietal and posterior temporal lobe, areas within those also are directly and exclusively involved in visual perception and visual analysis. And then the areas that I have these little network symbols are the areas that I spoke about as being the other 25% of our 50% of the brain being involved in visual functions. And these are regions within the parietal and temporal lobe, as well as way out in the frontal lobes. And then of course, in the deep regions of the brain within the basal ganglion brainstem, which are critically important in Lewy body diseases because Lewy bodies accumulate both within the basal ganglion brainstem, as well as in the cortical regions. And all of those regions that they accumulate in are involved in visual processing. So next, I just want to take a little bit deeper dive and notice that I've kind of flipped the brain here. So the occipital lobe is still in the back of the brain, but now it's to the right. So from that occipital cortex, there are 2 pathways. One is called the where or the action pathway, and the other is called the what or recognition pathway. So let's just talk for a moment about the where action pathway. As we move through the environment or reach for an object or avoid something coming your way or trying to plan motor movements, this action or pathway that we sometimes call the where pathway is very much active. And when we're trying to recognize something that we see, the pathway down into the temporal lobe is very active. Now, we've drawn them here as two separate paths, but of course, these pathways interact with each other all of the time, and they interact very, very quickly. There are interesting regions that don't overlap, so that they're sort of separated quite dramatically when we think about areas of brain function. But generally, there's a lot of overlap between these regions, and that helps you sort of see images and see the environment as one big activity that you're participating in instead of in a piecemeal manner. So let's move on a little bit now to talk more specifically about Lewy body dementia and the visual brain. So we want to sort of get down and gritty into what symptoms can you develop? How is the visual brain affected by the Lewy body dementias? So first thing I want to point out is that the 2017 criteria for dementia with Lewy bodies actually points out that a central feature in the diagnosis that's essential for the diagnosis of dementia with Lewy bodies is that in the early stages, prominent memory impairment might not actually occur, but instead deficits of attention, executive function, and visual perceptual ability may be prominent. And that is exactly what we see. And that is what happened to Mr. RS. And so you might ask, well, what is the reason for that? Why would we see visual perceptual ability be a prominent feature early on without memory impairment, despite the fact that we're calling it dementia? Well, you heard from Dr. Holden how we diagnose and use the term dementia. It doesn't only mean that a person has memory impairment. So often, cortical Lewy bodies will accumulate or impact the posterior cortex of the brain first. And by often, I mean in the majority of the time, when we find cortical Lewy bodies impacting function, it's at the back part of the brain, the occipital cortex, the posterior parietal lobe, the posterior temporal lobes. So that's where symptoms begin. They begin where a person has loss of function or loss of cells. And these are regions that are heavily within the brain's visual networks or heavily within the brain's primary visual areas. So that's where symptoms begin, just like we saw with Mr. RS. And so let's go back to Mr. RS in year 3. Now, this is when Mr. RS originally presented to our team. And by that time, his symptoms had progressed, and he reported to us the following. They didn't actually trust his vision, especially in certain lighting environments. So if things were too bright or too dim, he really didn't feel confident that what he was seeing was really what the reality was. And he was no longer able to drive, and he stopped driving on his own after he was getting lost. And after one particular time that was very frightening to him. And he was beginning to misidentify objects. And this again depended on the lighting. If it was too dim or too bright, he had a very hard time identifying what he was seeing. And this was particularly true in a cluttered environment. So on a shelf in the kitchen or in the refrigerator where there's a lot of items to take in at once. And he reported that reading had become very taxing. He had several pairs of glasses to help him at this point, but none did. None really helped him get back to the level of reading that he was capable of. And then his wife pointed out that he did not see things that were directly in front of him, especially in this setting of clutter. And then a few other things that he reported to us. He unfortunately had recently fallen from a curb and was having a lot of difficulty going down steps. And he also was questioning new difficulty with short-term memory, But his anxiety was increasing, and he really wasn't confident that a lot of it was his memory, or whether or not it was anxiety preventing him from being able to lay down new memories quickly. Well, what we found is that he did have mild Parkinsonism on examination, and that was being manifested by slowing down of his movements as well as mild tremor. And he had to, of course, quit working because of all of these symptoms. And when we did test his memory, he was having memory difficulties, but not to the degree or to the extent of his visual brain dysfunction. And of course, at this point, if we had performed a PET scan on him, which we did not, a specialized PET scan called an FDG PET, which looks at metabolism, we would have found decreased metabolic activity in the posterior part of his brain. And in this montage of cuts through the brain, you can see in squares F and G, sort of this lack of color orange in the posterior cortex that we're pointing out here by arrows in this series. And trust me that these cross sections do represent the posterior part of the brain. And in fact, in square F, you can see the eyes and the nose. And just to sort of reorient, we've also added in the upper right part of the slide that diagram that you were used to seeing. And what we're seeing is a cross section through the brain that shows these occipital parietal regions as well as occipital temporal regions. And we see this hypometabolism because that represents an area of the brain or areas of the brain that are not appropriately responding to information. So they have impaired function. And we believe this is due to cortical Lewy bodies in that area. And of course, as Dr. Holden pointed out, we don't see cortical Lewy bodies on scans. We can't see them until we look at tissue under the microscope after somebody has passed away. But we know from years of data and analysis of people that we see cortical Lewy bodies in those posterior parts of the brain first. And you've just learned that those posterior parts of the brain are very important for vision and vision perception. So you might be asking, why did it take 3 years before this was even discovered and eventually diagnosed in Mr. RS? And that's what we're going to talk about now. We're going to talk about visual brain symptoms, the recognition and assessment of those, to help us understand why it took so long. And it's really not easy. First, many physicians are not familiar with visual brain symptoms or even how to assess for visual brain dysfunction. And this includes eye providers and neurologists. And screening tests do not adequately assess visual brain dysfunction. For instance, Mr. RS scored very highly, 29 out of 30 points on his screening tests. But know that there are many clinical researchers that are working to change this, and that includes our team at the University of Colorado, LBDA, Research Center of Excellence. And in fact, we led a recent manuscript that should be published soon that essentially gives consensus recommendations for assessment of posterior cortical visual brain functions. And hopefully that will be published soon. So with publications like that, sessions like this, we are hoping to increase awareness of visual brain assessment, visual brain symptoms. And so let's take a little bit of a deeper dive into the symptoms of visual brain dysfunction. And if you recall those 2 categories I mentioned, they each make up 25% of the brain, the dedicated visual regions. We know that you can develop symptoms of impaired function, impaired vision, when you have impaired basic visual functions, spatial perception, and object perception. And we're again going to dive a little bit deeper in this in the next few slides. And then we have those visual network regions, and you can develop symptoms from impaired visual network regions, and they'll present themselves as reading impairment, complex visual task impairment, as well as visual motor, we call it, dysfunction, that Dr. Van Dok is going to speak about. That includes eye misalignment, and therefore double vision, decreased blinking, and therefore dry eye, sometimes manifesting as blurred vision, and then finally, visual hallucinations. coming from the brain, not from the eye. All of these that I am speaking about come from the brain and not the eye. And so let's review that in more detail. And let's look at Mr. RS as an example. His basic visual function assessment was performed, and let's see how he did. Overall, he had what is called reduced contrast sensitivity. So let me review how we were able to diagnose that. We can use a chart such as this to measure contrast sensitivity. It shows you letters that are exactly the same size, but have decreasing contrast, meaning there's a decreased differentiation between the letter that you're trying to read and the background. And so a simple assessment for contrast sensitivity measure is to just see how many letters on the chart you can read. And for instance, Mr. RS was able to identify 10 letters, so not able to identify as many as you would expect with intact contrast sensitivity. So that's why we diagnosed him as having reduced contrast sensitivity, which we consider a basic visual function that comes from that back part of the brain. Next, we diagnosed him with impaired color hue detection. And here, what you can see are swatches or squares of different color. And in this example, that upper left square should be chosen as the square that does not fit with the rest of the color hues that you see that all other squares share. And Mr. RS wasn't able to pick out that upper left square as being different than the rest. And so in that case, we diagnosed him with color hue detection impairment. Next, we're going to look at something called crowding. So I'm going to take a minute to describe this. You can have crowded text, crowded strings of letters and digits presented this way. So limited space between these letters and digits in this string. And then a non-crowded presentation would be more spaces between these letters and digits. So we call this a crowded presentation or a non-crowded presentation. And what we saw with Mr. RS is that he was able to read that string that was not crowded with a little more ease than we saw him read the crowded string, which he struggled with. And so, let me go back there for a second. So with the crowded string, his struggling allowed us to say that he is having decreased basic visual functions that we would label as crowding. So we went on, we didn't stop there. We went on to also assess spatial perception and object perception. And he was impaired in all of those. I've only shown you basic visual function assessments, but with further assessment, we also saw spatial and object perception impairment. So how would these manifest then, all of these, how would they manifest in symptoms? What might somebody describe? So just so we can again understand this at a little more depth. So for his basic visual functions that we just spoke about, the crowding problem, the problem with color hue perceptions, and the problem with contrast sensitivity, this we felt really led to his symptom that he expressed that he doesn't trust his vision. And then his spatial perception impairment leads to getting lost, even with good memory, leads to problems with visual spatial perception and depth perception. That involves where he was describing symptoms of judging steps and curbs. And then how about impaired object perception? What might someone complain of or have a symptom of? It might simply be misidentifying objects, or it can even be faces or people that you know that you can identify when you hear their voice, but you can't identify them by just looking at their face. So it's not a problem of memory, it's a problem of getting visual information into your memory regions. And of course, lighting and color, as well as clutter, can all create a challenging visual environment. So bright lights, dark lights give you fewer clues as to what you're seeing and don't allow you to use some of those clues to allow you to recognize things, to allow you to understand visual spatial relationships. And then clutter can make it very challenging. And I don't mean that it has to be, clearly an unkept type of scene, but it can simply be a lot of visual stimuli. And again, as I mentioned, in a refrigerator or on a shelf or on a inside of a drawer. So combine these, all of these can lead to great problems with using your vision to function on a day-to-day basis. So I've talked about those dedicated visual regions. Well, what about the visual network regions? Well, in time, Mr. RS displayed some pretty severe visual network region problems. So he, in time, was unable to read at all. He was unable to perform complex tasks that relied on his vision, and he unfortunately developed visual hallucinations, as you heard from Dr. Holden, which are quite common. So there's a large spectrum, and they may show up using different words by different people. So the large spectrum, as we've seen some of these, is they may be wayfinding, using your vision to find your way throughout a store or even your home, finding things directly in front of you, especially when there's a lot of visual stimuli, identification of objects or even individual letters and faces, judging steps, curbs, terrain while walking, and then performing complex tasks that really rely on vision, such as driving, reading, or even using a computer or smartphone, and even getting dressed, and then visual hallucinations. So we really see the full spectrum, and what somebody starts with and the combinations that they have are different in everybody. But reading is a very common initial symptom. So what we're hopeful for is that one day practitioners, both eye practitioners as well as neurologists, will start to incorporate visual perception testing into their office testing. Simply asking a person what they see during an assessment, which includes not only letters on an eye chart with very high contrast, but we hope they one day will start to use images that rely on visual brain functions, so that if you're 20/20, you have good vision, clear vision on an eye chart, clear eye function, you are then given tests when you're having problems that rely on your brain to figure out, such as this figure of overlapping objects and the figure that shows the makeup of the letter H by small letter E. So we're doing more than just trying to promote the use of these tests as screening tests that are important for vision. We've also designed the Colorado Posterior Cortical Questionnaire, which captures problems related to dysfunction in the posterior regions of the brain that could be sensitive enough for screening in Lewy body dementias, but we're not certain yet. We're still studying that. And the questions are self-reported. There are 15 questions, and here I just show 5, but they ask simple things like any problems seeing objects in front of you, problems with depth perception, etc. And we do hope that this can be employed as a very quick way to determine whether or not you should go on to measure and assess visual brain dysfunction. And I really do hope you've learned a lot so far about visual brain function and Lewy body dementias. And I just have a couple more slides to mention where you can learn more. So first is at our center, we have something called the Colorado Posterior Cortical Atrophy Support. And this involves both webinars as well as web pages. And you can go to our web pages. You can use that QR code, aim your camera on your phone right now at the QR code. That'll bring you to our web pages. And if you do that afterwards, you can simply Google Colorado Posterior Cortical Atrophy Support. You go under what is PCA and then tips for living with PCA. And there is a document there that will describe for you visual brain dysfunction, and then tips that we have taken from a lot of different sources, including other LBDA centers, as well as others interested in cortical posterior functions, and from our patients. So we have suggested ways to help. And you're going to hear more about that today from the rest of our team. And then lastly, I just want to mention this seminar, this webinar. It was given in 2015, and you can find it on YouTube. And if you just search More Than Meets the Eye, Vision and Symptoms of PD, you'll find this lecture by a colleague of mine, Dr. Daniel Gold, who is a Johns Hopkins neurologist and neuro-ophthalmologist. And he gives an excellent presentation on understanding common eye movement disorders and Parkinson's disease, but also visual issues that come with Parkinson's disease dementia, as well, and almost by default, in dementia with Lewy bodies. So I thank you so much for your attention and your interest in this subject. And we really do say healthy brain aging starts here, because educating yourself will, of course, improve your ability to recognize your symptoms and take charge of improving your quality of life. So again, thank you very much. And I'm really pleased to introduce Dr. Erin Van Dok. Dr. Van Dok is an optometrist at the University of Colorado School of Medicine, and she's part of our LBDA Research Center of Excellence. And I think she may have to correct me if this is wrong, but I think it was about 10 years ago that we started to partner and see patients with Parkinson's disease dementia, as well as dementia with Lewy bodies, to help solve visual problems. And so I'm really pleased to introduce Dr. Van Dok, because we've been working together in partnership, and it's really been a terrific partnership. She's helped so many of our patients. So Dr. Van Dok, you can take it away.
Thank you so much, Dr. Pelak. That was an excellent talk, and I learned a lot. In fact, getting to listen to all those details. So I hope everybody else really took a lot away from that. As Dr. Pelak mentioned, I work with vision issues, more simple eye issues that show up in our patients who have movement disorders, such as Parkinsonism and dementia with Lewy body. And I'll jump in with you here to talk about something that presents itself on a really regular basis. These are the topics that we typically run across in my clinic. Dr. Pelak will refer patients to me, or we'll have patients referred in from outside neurology or inside neurology, or even other specialties, to have vision evaluation when complaints arise in our movement disorder population. So you'll see oftentimes dry eyes due to reduced blink rate, blurred vision, variable vision, problems with moving the eyes around, having double vision, or fatigue or difficulty with reading. Trying to move my slide. There we go. It went a whole bunch at once. Let's go back. Pardon me. All right, so first off, going to just talk about dryness of the eyes. Our eyes certainly do get drier as we age. We're not as good at producing normal, comforting tears as we get older. And part of that is just physiology with time. But dry eye is also a very common problem with Lewy body disease and Parkinsonism. The typical symptoms that will present could be variable and blurry vision, and this can happen at any distance. For instance, even while driving or sitting down to read or sitting in front of your computer. People will describe discomfort, feeling like there's little rocks in the eyes or a burning and stinging sensation. And oftentimes there's even excessive tearing, which I know sounds counterintuitive to dry eye, but this is your body trying to fix the dry eye when in fact it really doesn't do a good job of that. There can be redness, either generalized or localized, sometimes itching, because allergy symptoms often go along with dryness, and there can be light sensitivity. When your cornea is impacted by dryness, the surface is irritated and slough cells And so light just cannot pass through your cornea nicely, and you end up with some light sensitivity. So as we know with Parkinson's, oftentimes blink rate is reduced, sometimes to only a couple of times per minute. This is down from a normal blink rate, anywhere from 16 to 18 times per minute. So you're not getting that nice windshield wiper effect because of the reduced blink rate. Additionally, there's medications that can exacerbate dry eye symptoms. And obviously from this list, there's a myriad of medications that can do that. We're probably not going to change many of these medications simply because of the side effect of dry eye, but it is something to consider when you have somebody who is maybe taking an antihistamine on a regular basis, or is even using an artificial tear that has a preservative in it real frequently. Antidepressants are common to be a side effect of dry eye. So take a look at what you're using, and if there's something there that can safely be eliminated that might be causing some dry eye symptoms, it's a way to try to manage yourself. So as I said, dry eye can be managed. Dry eye is a disease, an ocular surface disease that is not curable at this point in time, but it can be managed. There's good reasons to manage dryness because it can really improve your ability to function every day. You're going to have better clarity of your vision. You're going to experience more stamina for doing things with your vision, such as driving or reading or sitting on a computer all day at work, watching television or doing near-point activities that are detail-oriented. Your eyes will feel better if you manage your dryness. So there's certainly simple ways to help with dry eye symptoms. The big first one is just start using a little bit of moisture in your eyes. And this is not throwing water in your eyes. This is getting artificial tears, which you can purchase at the store, any store, Target, grocery stores, etc. We don't want you using the Get the Red Out drops. Those actually tend to cause more trouble, but we would love to see you using artificial tears at minimum bedtime and in the morning. You could also consider using what's called a gel tear or a liquid gel or moisturizing gel at bedtime. These are also artificial tear products. They can be found in the same area of the store that you would find artificial tears. These are thicker, so they're going to be cause a little bit of blurry vision. So you typically want to use those at bedtime. You can humidify in your living space. Certainly right next to your bedside is a great place to have a small humidifier. A warm, wet compress with a little gentle lid massage. Reading and computer use in little shorter segments. People have a tendency to go down those rabbit holes, so to speak, and stay at a computer for hours on end. And that's very tough on dry eye issues. And the other thing to do with your loved one who may not have a full normal blink rate is say to them, if they're starting to experience some blurry vision or discomfort with dry eye, say, let's stop and have like 5 big blinks. Slowly blink those eyes with purpose. So here's a list of some popular artificial tears that are available, as I said, over the counter. The ones on the left are just the regular tears that you can find in little bottles. They also come preservative-free. Preservative-free means they come in single dose little packets, and you can rip off a top and use those teardrops just for that moment in time. The other products are the gels, and they are thick. Some of them come in tubes that look like an ointment tube. Others do come in regular bottles. If you need a little help getting those products into your eyes, a lot of people are nervous about putting drops in their eyes. One way you can help yourself is to lay down on your bed. If you have clean eyelids, you could even drop tears right onto the corner of your eyelids and then blink it in if you are indeed afraid of looking at a dropper coming at you. And then these two little tools are a demonstration of something that can hold a bottle away from your eyes while allowing you to manage to get the tears to your eyes. As I had mentioned before, a warm, moist compress, such as a washcloth, applied to the eyelids on a daily basis with some gentle wiping and some gentle massage can improve your tear film and help you reduce dry eye complaints. This happens because we have little oil glands along our eyelid margins that tend to get backed up. And then that tear film layer that prevents our tears from evaporating so quickly gets compromised. So doing this daily can feel really good. I encourage people to try to do this maybe at bedtime, a little bit before you put in some artificial tears for the night. There's also things called moist heat masks. You can find these online. They're reusable. You can put them in the microwave, I think typically anywhere from 30 seconds to a minute for heating them and then applying them to the lids to allow that heat to work again on those little oil glands. There's medications for dry eye. These are all prescription medications, so you would need to see your eye doctor about this. And I can tell you that there is no magic. Again, not a curable problem, but a manageable problem. So oftentimes when we use these medications, there's some long-term use involved, and we're doing it in order to suppress some inflammation and then see if we can't manage you continuing with just using some additional moisture in the form of artificial tears. Other interventions, as I mentioned before, humidifying in your bedroom space or living space, cleaning your eyelids. These particular products are focused on being antibacterial along the eyelid margin because accumulation of debris on the lashes, which that's what eyelashes are for, catching debris that's moving around or flying in the air. But removing some of that can also help with the tear film. And a fairly intensive intervention would be for somebody who we've tried other things with and perhaps are not getting good results in terms of dry eye complaints. This is called blood serum tears. This is a prescription also by your doctor, and your blood is drawn, serum is centrifuged out, and then they are diluted in order to create an artificial tear that is made effectively by you. So you're increasing your immune factors by placing these tears back into your eyes. So let me jump forward on the eye misalignment, eye coordination problems that Dr. Pelak had mentioned. I see a lot of this in my clinic on a regular basis. So as you had heard from the prior talks, eye movements can be impaired by these diseases. You can have difficulty moving your eyes from one object to the next. This is called saccadic movements. This can be an effect on you when you are trying to read, because we need to move our eyes from word to word to word, or sentence to sentence, object to object. You can have difficulty following a target or object through space. This is called pursuit movement. This affects you, for instance, when you're trying to drive an automobile. You have dynamic movement of other objects. constantly around you while you are driving, and you need to be able to follow those smoothly. And then there's difficulty moving your eyes together or apart. This is called convergence or divergence. Our eyes are meant to converge when we take a look at a near object. But for instance, you may look at something at distance and then you have to take a look at something at near, and that's a vergence movement that you need to complete. So ideally, our eyes do move in a coordinated manner, and to place the light from a target, an object that we're looking at, onto the most sensitive part of our retina in the eye called the macula. This is a very complex system, as Dr. Pelak pointed out. We have 6 muscles around each one of our eyes that have to respond to nervous system input and balance system input in order for us to move safely in our environment and to perceive things in a normal, clear fashion. All right, so if you have an impairment in this movement or eye coordination, you can end up with a lot of different issues. Blurring vision, overlapped images, difficulty with balance, fall risk is increasing. You could have jumping or shaking visual targets, reduced ability to scan in your environment, difficulty watching rapid movement happen, trouble with computer use or reading, or even separated images or double vision. So you saw that slide come in, what double vision can look like. And you can see how exhausting double vision can be. You can have images that just simply appear overlapped, so they look incredibly blurry. You can actually have full separation of images. This can occur vertically, diagonally, horizontally, and in any kind of position. So I have some simple tips to help with eye movement issues. When you have compromised vision issues, think about how to prioritize your vision. So for instance, if you have 2 or 3 tasks that are visually intense that you know that you need to complete in the course of a day, let's choose what you want to work on first. Because sometimes when you're compromised, you may have to say, this is all I can manage today. Unfortunately, you can expect some fatigue and blurring after you're doing intense visual activity. So this may be at work, working on a computer for hours on end. By the end of the day, you may in fact be very blurry or have difficulty seeing well at distance for driving. This may require that you work in shorter segments. Avoiding rapid gaze changes. So I have a lot of patients who perhaps have fairly strong binocular vision, their ability to use their eyes together when they are in a primary position of gaze, looking straight ahead. But if they look to the right or look to the left, they may in fact break down. This is, again, all these eye muscles are having to get input on keeping this visual target as a single image. If this is the case, I'll say, hey, why don't you try for a moment, either resetting, close your eyes for a second, turn your head into that position where you know you have more strong binocular vision, or just shut your eyes for a moment before you look over to one side, knowing that if you do have some double vision, you may need to stop and reset again. Back to using moisturizing drops. Do this prior to extended visual effort. So if you know you want to sit down and read a book for the next 30 minutes, put a couple of artificial tears in for a few minutes ahead of that and blink that out so that you get better clarity of vision. Taking breaks from visual tasks when you notice you are having difficulty with the clarity or you're getting double vision. So don't push yourself. the reality is, we can try to improve some of these things, but you may not be a 3-hour reader anymore. You might be able to say, okay, I can get 30 minutes of really good reading time in, and then I need to go do something else with my vision for a little while. So the most common eye coordination problems seen in these diseases is something called convergence insufficiency. This is a vergence problem, and this is the diminished ability to use your eyes as a team when you're looking at a near object. This can cause great difficulty with sustained and comfortable reading, and this is something I deal with all the time. So here's a little schematic of what that is like, so you can kind of get an idea. Our eyes, when we're looking at distance, are effectively in parallel. When we look at a near object, they need to turn towards that near object. So we can manage convergence insufficiency. So this is going to start with finding a vision care provider who will do an extended assessment of these vision issues. And that isn't every eye care provider that is out there. In fact, it's a minimal number of eye care providers out there who can take a look at all of these issues and then sit down and make a good plan with you to try to help you use your vision better. When I see somebody in this situation, one of the first things I'm going to do is refract you, check your prescription. And this is so that I can optimize your ability to see well, because optimized vision is the first piece of input that we want in order to get the best flow through the brain in order to perceive things properly. I'm going to look at your eye movement. I'm going to look at your ability to coordinate your eyes. I often and almost always end up putting trial lenses on a patient. That's what you see with this gentleman right here. This is your prescription, and I am looking at your ability to coordinate your eyes using your optimized prescription. And as I said before, the biggest complaint I often see is related to near vision and related to this convergence problem. So we're going to have a long talk about the things that you do with your vision when you're looking at a near object. So are you trying to read a newspaper? Are you trying to do hobbies? Are you doing all your reading on your phone? How much computer time is there? Do you have a desktop computer versus a laptop computer? These are all really important pieces of information when we are trying to tease out the best way to help you use the vision you have. Typical complaints that come in related to near vision: not being able to read as long as you used to, trouble focusing, seeing double, having to close an eye to see well up close, rereading the same line, trouble remembering what you're reading, getting tired, losing your place, and some people having even given up reading at that point. So when I prescribe glasses, which, I do as appropriate, but oftentimes it requires at least 2 pair. This is tedious and unfortunate and difficult for patients, sometimes especially when you're having trouble remembering where things are. So sometimes you're going to have to consider having 2 pairs of glasses on, one that's hanging from you and one that is on your face. You want to get comfortable, well-fitting frames. You definitely want to get frames that appear to be different, perhaps different colors. I had one gentleman who I had prescribed 2 pairs of glasses, and he ended up going out and getting the same frame and was continually confused about which was his faraway vision and which was his reading vision, and ended up walking around with reading glasses on, which is a problem for a fall risk. Sometimes posture dictates that you may have to have a little head strap on your glasses. Many of my patients have a very forward pitched posture, and so we want to make sure those glasses fit well. You want to have a sense of humor. I know this is frustrating to have multiple pairs of glasses, but ultimately we are looking at the ways to make the quality of your life and your vision more comfortable. So the biggest tool I use when I do have double vision or significant problems with convergence for a near point object is using prism. You remember prism in your physics class, and they look like little triangular lenses and they bend light. And so prism is just an optical tool that changes the position that you perceive an object to be so that you have less effort to try to fuse those images. Remember, we have two eyes. If two eyes are working well together, we should have a single image. When the two eyes are not working well together, we have a double image. This would be a situation where I have one eye that just simply cannot work with the other one. And this can come up in situations where we have another disease process going on. Perhaps we have macular degeneration and we have one eye that sees 20/70 and one eye that sees 20/20 or 20/25. Our brain has a hard time putting those images together without causing rivalry for the better eye. And so if I have tried every other avenue to get these eyes to work well together by optimizing vision, and cannot do so, sometimes we will have to fog a lens to encourage the eye that is not providing good vision to not pay attention to the image at hand. This is certainly not ideal because we do reduce depth perception or eliminate it effectively when we take one eye out of play. So it's not anything I take lightly when we do this. But you'll see on that image on the left, sometimes a little bit of Scotch tape across a lens can initially help us find out if this is going to be a successful option. And the only time I would use patching would be for intractable double vision. In other words, we cannot make this double vision go away. And this does happen sometimes in more advanced neurologic disease or in someone who has double vision in really variable positions of gaze that changes in the magnitude of its double vision, so that we cannot prescribe a lens that will work for all of these positions of gaze. So back to near vision and how to enhance it. Bright directed lighting can be very important for printed material. And you can see these are gooseneck lamps. And you can even get gooseneck lamps that are very fancy and can change the color temperature of the light. So if very bright light is bothersome to you, you can alter that brightness, but you put that light onto your reading material rather than having ambient light around you. Increasing the font size of the print you are looking at. You can certainly do this with electronic devices. You should go into accessibility features on your phone and alter these things. Make your print bigger, make it easier for you to see. There are large print items, but anymore, which you can see in the War and Peace novels are gigantic here, but anymore, so many people are reading with electronic devices. And for instance, a Kindle would be one way to increase your reading font without having to get a large print item. Stabilizing your reading material, sometimes even bringing it up so that you don't have to be completely into down gaze position, so that you can be more in an intermediate or straight ahead gaze position can be helpful. And certainly if there is a tremor while you're trying to read, having something to stabilize your reading material can be very helpful. If you're having trouble with contrast, a reading line guide can be helpful on printed material. A lighted stand magnifier would be something that you could set aside to look at magazines, whatnot, without having to hold a magnifier and providing yourself with that directed light. And if worse comes to worse, if you can't make sense of what you're reading or having such difficulty with your visual input that it's just not possible, read with a friend. Have somebody else help you out with this. And if your eyes won't cooperate, recruit your ears. Oftentimes, my patients who just are struggling with their visual input still have very good audio input. And so listening to audiobooks, which you could get from your local public library or from these paid services, or in Colorado, we have a special nonprofit library that can provide this service by either sending audiobooks through the mail or even sending them over your computer. Can be a great way to still get stimulation without being able to see it well. So in the end, ultimately remember that an annual comprehensive eye examination is still a necessity, even for someone who is having difficulty with movement, because there are other things that can happen with your eyes and have an effect on your vision. And that would be things like development of cataracts that happen normally with age, development of macular degeneration, which is an abnormal problem that happens in some individuals with age. You could develop glaucoma and have a sneaky way of vision loss that you have no recognition of because you would not have symptoms of this. There's a myriad of things that can happen. So we need to know your eye health status, manage those things that we can manage, and then we can work on improving your visual status and your visual input so that we can improve your quality of life. So thank you so much for allowing me to present this information. Our next presenter today is Erin Hookstadt. She is an OT who has 25 years of experience in working with neurology. And we like to go to our OT when we're seeing individuals who are having a struggle with their activities of daily living, perhaps difficulty navigating their environment, or difficulty with their driving, and we need them to be assessed to find out if indeed this is a safe activity, despite perhaps good vision function. So here is Erin.
Thanks so much, Dr. Van Dok. Thank you for this invitation today to be a part of this discussion. As you will find that I will probably be reviewing some of the things that both Dr. Pelak and Dr. Van Dok just described. As mentioned, I work at the University Hospital with many years of experience in neurology and work very closely with Dr. Holden, Dr. Pelak, and Dr. Van Dok. So today, I will be covering the following topics. In your team, what would be the occupational therapist role? As already described, but what are visual perceptual skills? Discussing adaptations or equipment for your home. Discussing home evaluations and how that can look, either using a home health agency or what we have found with telehealth medicine, how we can now do that currently in an outpatient setting. We'll discuss and give some options, as somewhat mentioned already by Dr. Van Dok, in regards to setting up your phone and or computer suggestions. And then a unique program that we have at university is the occupational therapists perform a clinical driving evaluation. And we also partner with some community-based therapists that actually complete an actual driving evaluation. So as an OT specializing in neurology, our evaluations could specialize in focusing in any one of these areas. So very specifically, if someone does have a tremor or rigidity or limited arm movement, we can focus there on our motor skills of our arms, our range of motion, our strength, our dexterity. As mentioned, we will also evaluate our cognitive skills, attention, working memory, our speed of processing. And the umbrella term used for all of these skills is executive functioning. Again, including working memory, our focus, planning, time management, flexibility, and ability to achieve our goals. In OT, we can evaluate functional visual skills. And we have some standardized tests that go a little bit further into visual perceptual, but also our visual attention and some of our eye movements that Dr. Van Dok spoke of. And if it's appropriate, if an individual has prisms, how can we do some functional training with the use of these prisms in their ADLs? I think a home evaluation is always helpful. Again, this can be completed but through a home health agency where you live, or in outpatient, we utilize telehealth. So someone might have a laptop and I might ask them to move around their home, a family member to move around their home with the laptop while their loved one or the person that I'm hopefully trying to provide strategies to is performing various tasks, either in the kitchen, maybe transfers in the bedroom, or analyzing or looking at the bathroom. And then again, what we'll describe later, the clinical driving evaluation. So an individual, as described through Dr. Pelak and Dr. Van Dok, can experience impairments in their visual perceptual skills. And this is our ability to organize and interpret the visual information seen and give it meaning. So all of our activities of daily living can be impacted. Orienting clothing, performing our grooming tasks and mobility. Again, locating, scanning, identifying objects. Preparing meals, managing our medications and finances. And as mentioned, all the challenges that come with reading. Spatial navigation, what one might describe is this difficulty or getting lost when driving, or difficulty with lane alignment, or depth, which will be present during parking. Some of the eye movements that in therapy we may be looking at is also that convergence, that inability of the eyes to move inward and remain focused on near point activity, and how this makes reading difficult or whatever our leisure task is. The saccadic movements are these rapid eye movements that can occur between objects. They can be small amplitude or large amplitude, and it's the small amplitude movements that again impact one's reading abilities. Pursuits or scanning, but pursuits is really our eyes being able to smoothly follow an object in all directions. So some of our standardized testing in occupational therapy can look at our visual perceptual skills, and they break it down into these top 5. So visual discrimination, our ability to identify differences in visual images and objects. Spatial relations is that orientation, Do I know where this object is in space? Is it up, down? Is it rotated? Is it backwards? Visual memory, our ability to recall visual information. Figure ground, the ability to identify an object or a figure from the background. Visual closure, the ability to identify forms or objects from an incomplete presentation. So part of the object is covered or hidden. And then in many cases, we work with individuals that may have a visual field loss. This could be part of vision in one quadrant or one hemisphere, in one eye or both eyes. As mentioned, what I think is always helpful is a home evaluation to truly identify the barriers or the hazards so that we can reduce fall risks. There's a wide variety of durable medical equipment available that to promote that safety in the areas of highest fall risk, which is in many cases the bathroom. And these recommendations can come following that home evaluation. In the Denver area, there's a company called Accessible Systems. They actually have a show home located in Inglewood. And I believe it's like Federal and Santa Fe location. What's nice about this show home is that it does allow you to browse the various types of equipment that could be available to help with mobility, ramps, and they have sections of the home that show modifications. So if you are exploring that, yes, we may need to do a simple modification in our bathroom, what might that look like? And what would the costs be? Dr. Van Dok went into the lighting considerations in certain areas of your home, how we do need to increase it or install dimmer switches to allow for that ease of adjustability. Fluorescent lighting is frequently used. It's inexpensive and energy efficient. However, it doesn't provide the best contrast. So also using those incandescent flex arm lamps to really help you with that near point activity, whether you're reading or a craft project. So obviously some of the recommendations that we would support you with at home is truly increasing the brightness and increasing contrast in your home. That would allow us to locate our commonly used objects. Also, when we come into our home, maybe we choose an anchor point. This is one location where we're attempting to leave our phone, our keys, our wallet. Place our commonly used objects on contrasting color. So for example, you could place a light colored comb or brush, but on a darker colored tray. Labeling drawers or cabinets, or placing a sign at eye level. Definitely decreasing clutter. Very important to help your loved one navigate within the home and promote independence in their activities of daily living. Arrange your furniture in a predictable manner. Many items of our clothing no longer have tags, and so it can be really difficult for an individual to orient their clothing inside out, front, back. And so sometimes I will use a bright contrasting color fabric paint on the back of their clothing if that would help them orient their clothing. And then when possible, how can we use our other senses to navigate in a new environment? So continuing in your home setup, think about maybe your light switches. So many of them just blend into the paint color. So could we use contrasting tape, the red or the yellow electrical tape to outline our light switches? Think about where we're placing mirrors. Should they be placed? we don't want them to be placed where they can create the illusion of another room or possibly another person seated in the room. For writing out our task lists or our grocery list using a black felt tip pen with very large, bold lined paper. There are so many, and in therapy, we explore all different types of like daily planning sheets. They can be large, they can be bold. Today's date is on the top with a large slot for the time. And then how are we going to somewhat organize or schedule our daily activities? And Dr. Van Dok went into lots of options in regards to so much is now available on the market in regards to large print books with bold contrast. And again, she demonstrated the contrasting line guide, or sometimes I'll have someone use a ruler. And then on the ruler, again, I use that same bright red electrical tape. I place it along the ruler. So it really helps to guide your eyes to the page. And then again, illuminating that page to promote whatever reading one can do with more ease and successful. If you have an animal, maybe reading out loud, because reading out loud helps us with retention, provides us with those auditory cues. Getting dressed. I think it would be really helpful to organize our closets into sections. So we're separating shirts and pants, or maybe we're placing an entire outfit on one hanger. And in that outfit also may include accessories, whether it be a necklace, a belt, whatever. The same with organizing our clothing drawers. How can we best organize those, or possibly place a photograph or something to help that individual identify this clothing item when they're beginning their morning routine? Possibly eliminating clothing that's just not worn frequently or out of season. So the organization and the predictability and the setup of that in your home is so helpful to promote independence and reduce fall risk. I feel we always want to, in OT, explore helping the individual engage in occupational tasks. This helps them fulfill that need to be productive and also be supportive to their family members. And we explore leisure. You know, maybe one activity that they performed in the past, they no longer can. There's so many other options for visual or cognitive activities that are now large print that they may enjoy. And so in therapy or with loved ones, maybe they can explore these leisure interests. Again, on your phone, let's think about increasing our contrast and increasing the text size. You can also increase the brightness. On our home screen, let's remove the apps. Let's move them off to the second page so that the first page are the apps that the individual uses on a daily basis. Let's simplify. Or maybe some practice and training and education in the use of possibly using Siri to text or call, or some smart home devices and how those devices can be set reminders for either medications or appointments or adding things to my grocery list. Your computer, Dr. Van Dok spoke of this. There's a lot that you can explore in your accessibility setting now, where possibly we could try some voice to text. There are, again, this is where if you had an OT evaluation, they could look at very specifically what you're struggling with. There's so many resources out there. But there are keyboard guards. If you have a tremor, that reduces the chance of pressing unintentional keys. You can change the sensitivity setting on your computer. for your keystrokes. Slow down the mouse or the cursor speed. There are larger keyboards with bright contrast. The steady mouse, if one has a tremor, it detects and removes the shaking motion before it reaches the cursor and can block some of those accidental clicks. So my next section is I work very closely with the physicians. And I thought it was very instrumental that we had this type of assessment at university. And so when a physician or a patient or family member are wondering, can my loved one continue to drive? Maybe do we have to consider that they might be able to drive, but it looks different where it is a restricted license? Or in many times we do have to have that very challenging conversation that it's time to retire from driving. So at the university, we complete a clinical driving evaluation. It's 90 minutes in duration. This is covered by your medical insurance. I'll show you, hopefully these videos will work, and I'll show you a couple of clips of this equipment. But what are we assessing in this clinical evaluation? It's not a driving test, but it's pulling out the skills we use when we drive. So we're looking at your visual attention, your visual scanning and processing speed. We look at your physical reaction time. How quickly can you transition from the accelerator to the brake? We have some very challenging but helpful computer-based testing that looks at our central vision. How well or at what speed are you processing information as you're looking directly forward through the windshield of the car? And then in addition, when your eyes are forward, looking through the windshield of the car, how well aware am I of things around? So I'm now measuring your peripheral vision. And then we do some standardized cognitive testing and screens. So this image on the slide, the machine is called the Dynavision. Most people like utilizing the Dynavision. It gives us and the individual some very objective information and data. So it's 4 foot by 4 foot. And what I'm looking at, and we do 3 different assessments. I'm looking at your visual search pattern, left, right, top, bottom, and your reaction time and your speed of processing. So for example, I'll show you like a 30-second clip. One of the tests we do is a 1-minute test. You're standing in front of this board within arm's reach. It counts down and you can see all of these lights on the board. A red light, one of those will be illuminated. You're doing this visual search pattern, looking for that red light, and you press it as quickly as you can. As soon as you press that light, there's another one. And the goal is how many lights can you search for and press and complete in 1 minute? And we have norms on all of this. But I think what's even more important is when one is done, we have a computer printout or description of where are your strengths, where are you scanning well, and where might it be slower compromise, and how can we work on that? Another item we use is called a physical reaction time tester. And it's just pedals and a red and green light. Your foot is on the accelerator, the green light appears. Randomly, the red light appears. How quickly can you move from the accelerator to depress the brake? One of the hardest things to maybe see on the video that we may not show today, but it's called the useful field of view. And there's been some nice research behind this computer-based program. And again, what is that assessing? Your central vision, speed of processing, visual information will come on the screen, and you have to select, what did I see? And the information will stay on longer if you need more time to process it, or it'll go really fast if you are processing information at a faster rate. And it also measures peripheral vision or peripheral awareness. And then we complete some standardized paper and pencil tasks, the Montreal Cognitive Assessment and Trails A and B. Whoops, I think I went too far. No, I didn't. So who can complete, or who do we recommend completing the driving assessment? These are hard to find. Since COVID, the Department of Motor Vehicles, or at least I can only speak for the state of Colorado, they no longer do the driving test. So trying to find individuals at a somewhat reasonable price to do this assessment is hard. But there is a network of therapists, in many cases, they're occupational therapists that have gone through this additional certification. And they are called Certified Driving Rehabilitation Specialists. And we work with 2 in the Denver area. I feel like I went, sorry. I skipped one, but so the cost, this is not covered by insurance. So in the Denver market, the cost of this is $300 to $350. So it's an expensive test. And the 2 companies that we have partnered with in the Denver area is called Drive with Confidence and Health Promotion Partners. Now, it's a physician. So the CDRS will complete the evaluation and give recommendations, whether the person could continue driving without restrictions. Sometimes an individual possibly could drive, but then now it's with restrictions, and their driver's license indicates that. It might be daytime only. It may be no highway, or possibly a certain number of miles from their home, which is typically lower speeds and overlearned areas. Or they are just unable to demonstrate the skills and the safety for driving, and then we discuss retirement from driving. To locate one of these type of professionals in your area, if you go to ADED.net, they have a listing of therapists that have this certification. But to review, in the state of Colorado, it's a physician, it's an eye doctor, or it's a physician assistant that can legally make these formal recommendations through a legal document to the DMV. The therapist or the CDRS are just, we're completing the evaluations and giving the information to the physician. So I am not so sure. Everything is grayed out on my screen, so I'm not sure that the video will show. Okay. Oh boy. It's somewhat blurry, but I think it'll. So this is one of our low vision OTs. She's pretty quick. So this is the Dynavision in action, but it's pretty blurry. So my apologies for the quality of it, but it kind of gives you a little bit of a glimpse of, she's pretty fast though, of how we do this visual search and scanning. And then at the end, there we go. The computer shows us the individuals, how many lights they hit in 1 minute. She hit 86. Her reaction time was 0.70 per light. And then it breaks down each quadrant and what was one's reaction time in the upper left, upper right, lower right. And then I don't know, someone else is driving the videos. If we could just try one more, not as important, but it just shows the physical the accelerator and brake. So we have norms on this. It's divided up between males and females. Sorry, again, it's a bit blurry, but right now, unfortunately, it's not showing the pedals at the bottom, but basically that's the physical reaction time assessment of how quickly you can transition from the accelerator to the brake. Thank you. I think maybe that was Dr. Holden that was helping me out there. And I think it's funny that Amy felt the need that she had to hold on to an imaginary steering wheel. Okay. I feel like that's good for my videos. And I hope that this information was really helpful. I want to say that I'm very blessed to be able to work with the physicians that are presenting today, as we have a very close working relationship. And if you're interested in working with a therapist in your area, definitely begin the conversation with your physician. Thank you so much for your time.
Okay, we may be having some technical difficulties. I don't know if we have Julia Wood with us at this time. It looks like she may have dropped off. So this is Angela Taylor from the Lewy Body Dementia Association. We knew that she was having a bit of technical difficulty, so I'm going to pick up where she left off. First and foremost, I really want to thank all of our wonderful presenters. This has been a fantastic webinar, bringing us a whole lot of new information that Lewy Body Dementia Association has not yet covered in other vehicles. So I hope you all have enjoyed this greatly. Let me pause now and ask, we've got some questions here that have been submitted. And I have not been in the chat, so give me just one moment here, because I see here that we also have some questions. Do we have if all of our panelists are online? I can see you. Fantastic. Thank you all. Really appreciate it. So I'm going to start with this first question for all of you. When I close my eyes and I'm not sleeping, more often than not, I have visions, sometimes designs, rooms, and scenery. An example is riding in the car with my eyes closed. I'll visualize a wooded area, and one time actually sensed that the car was turning. Opening my eyes, we were on a freeway with sound barriers on one side. Is this a hallucination, or do you have an explanation? Does anybody from the panel like to answer that question?
I can take that on. So we do have a special term for this, and we call it closed eye hallucinations. They're obviously very different than when your eyes are open, but what it helps us understand is that your brain will try to fill in gaps when your eyes are closed. So it'll fill in gaps sometimes of just activity that's ongoing that usually you're not interpreting, but also sometimes of visual memories. So when you decrease the activity going into those visual areas of the brain by closing the eyes, your brain starts to become a little bit more active to present to you visual information, even though you're not seeing it.
Thank you very much. All right, I'm gonna look to our questions submitted through Q&A as well. One of our questions is, does LBD always begin in the occipital lobe? Does anybody want to field that one?
Sure, I can start, and then Samantha can add, Dr. Holden can add if she would like, but it is a very prominent place to see. If we did a PET scan, like I showed you, it's a very prominent place to see hypometabolism, but we can see hypometabolism or other areas that are involved first as well. And that can include those other areas I showed you, the parietal lobe, the temporal lobe, and the frontal lobes. So it's not always the first place. And I also want to just mention that the brainstem and basal ganglia can also be some of the very first places that Lewy bodies can show up.
Thank you. I have a question for Dr. Holden. Are there any key differences between the types of visual symptoms that people report in DLB versus the PCA variant in Alzheimer's disease?
Very astute question. And it's a really important point in terms of our jobs as behavioral neurologists, where we're trying to figure out what the underlying cause, if any neurodegenerative condition is at play, of the person's visual symptoms. And also often requires multiple experts, right? The neurologist, the ophthalmologist, the optometrist, trying to sort out what's the eye, what's the brain. And I think that one of the important take-home messages from today is that a lot of stuff gets blamed on eyes, and people will go to their eye doctors first, whether it's an ophthalmologist physician or an optometrist specialist. And the ocular exam, the eye exam looks okay. And people are told, well, I don't know, it looks all right to me. And what we want to make sure is that the next step then is, but maybe it could be your brain. And that we can make sure we're screening people regularly, as Dr. Van Dok mentioned, like that everybody needs their annual eye exams, right? To make sure your eyes are healthy. It's so closely tied to our health and wellness overall, but that it's also an entry point into care otherwise, where if something's not seeming right with either how your vision coming from your eyes is working or the connection between the eyes and the brain. So what we will often see for people with posterior cortical atrophy, which is one of the quote unquote atypical presentations of Alzheimer's, we're trying to move away from atypical because it's probably much more common than we currently think, because we're missing it all the time, where people are going to eye doctors and not getting to neurologists. But it's often the things that get blamed on memory too, where it's like, well, I can't find my car in a crowded parking lot. And it's not so much that it's a memory problem, but that it's the visual scanning or being able in a cluttered scene to find your car, or recognizing people's faces. I've had people tell me, you know, my memory's bad, I can't remember who these people are. But as Dr. Pelak said, as soon as they talk, I recognize them, right? So that's not a memory problem, it's a visual problem. In terms of separating an Alzheimer's posterior cortical atrophy from a dementia with Lewy bodies, though, the visual symptoms can be very similar. It's more what else comes with it and which category do they fit in, because you can also have posterior cortical atrophy as a syndrome from underlying Lewy body disease. So it gets very complex very quickly. And so we look for those other clues that come with the visual symptoms. That screening questionnaire that Dr. Pelak mentioned, the Colorado Posterior Cortical Questionnaire, we're eventually going to see with our studies if we can distinguish a pattern of complaints of yes, no's to those questions that could help differentiate a Lewy body from an Alzheimer's condition underlying. But as for right now, we rely on the other clinical things that come with it, additional testing like brain scans, to try to help sort out which is which. And I think another one of the questions in the Q&A was, can you have more than one thing in your brain? And the answer to that is also yes. Where up to 80% of people with clinical Lewy body, that they have those features, they also have the Alzheimer's plaques and tangles in their brain, and that can cause more of an overlap and mixed picture of what people look like.
Thank you. So I have a question for Dr. Pelak. My mother was diagnosed with macular degeneration years ago and is for the most part blind. I'm wondering if she'll still have hallucinations. Also, are the hallucinations formed in the brain? So imagination plays a role in this dreadful side effect rather than sight itself?
Another really good question. And I would interpret that as asking whether or not, as the macular degeneration gets worse, will the visual hallucinations go away? And we sometimes see that people with macular degeneration, even without Lewy body dementia of any type, will develop hallucinations because of that lack of input. Similar to the other question, when you close your eyes, developing hallucinations, closed eye hallucinations. So we wouldn't expect, as the macular degeneration diminishes, that we could, I should say, as the macular degeneration worsens, that we could predict what will happen to the visual hallucinations. They could get worse, they could fluctuate, or they could really stay the same. I think Dr. Holden mentioned this, as well as Karen, when she spoke about the fact, and I think Erin did as well, is that we really see a lot of fluctuation. So you can see absence of certain symptoms for weeks to months. And I've even seen that happen for a year, and we don't have a great explanation for that. But know that having your physician to rely on to tell you whether the macular degeneration is getting worse and whether there's something you can do about it will be very important. Dr. Van Dok emphasized this, and I do with all of my patients, that you're optimizing your visual input will allow you to have fewer symptoms, even if they come from the brain. And you can check that out if you're a partner or a care provider, a spouse, a family member. You could put on a pair of reading glasses and try to walk down steps. You could put slightly opaque Scotch tape over a pair of glasses and try to walk in a grocery store. What you'll see is the decreased input doesn't allow your brain to process details in the same way. So even in somebody with significant visual brain dysfunction, we always emphasize to keep the eyes as healthy as possible, because garbage in will always mean garbage out. So even in the setting of macular degeneration, make sure you keep going to your appointments to make sure that those treatable parts of macular degeneration can be treated. And it's very hard to predict, in summary, what will happen to visual hallucinations as macular degeneration gets worse, but the needle would point towards potential worsening of those hallucinations.
Thank you. We've got a couple questions on cataracts and LBD, so I'm going to blend these together. Individuals with LBD who have had cataract removal surgery and are now experiencing a change in their distance focus. Will glasses help? Is this related more to the cataracts, or is it also part of the LBD? You know, what advice do you have for families who are in that? Because cataracts are not an unusual part of getting older, but what do you do when they coexist with LBD and you have vision issues?
Well, I'll jump in there. Certainly, our job is to try to tease out where these difficulties are arising from. And so, of course, the first thing you do is see your eye care provider, either your ophthalmologist or your optometrist, and we're going to look at, is this individual truly able to see? I do have individuals who I can prove they have vision, yet they cannot identify objects. They cannot make sense of what they're seeing. So Yes, you need to make sure that the individual who's had cataract surgery has an appropriate pair of glasses to give them their best distance, intermediate, near vision, whatever they need. Some individuals who've had cataract surgery actually no longer need distance vision correction. That might be a first for them during their lifetimes. But a lot of individuals post-cataract surgery still need vision correction. And so that needs to be determined. If you're providing best visual correction and yet you're still having these visual difficulties, then indeed, we're probably more assigning that to brain vision issues than eye vision issues.
Thank you. So here's a question I think a lot of people are thinking, and as my dad had DLB, I certainly would have thought about it too, but I didn't know that there was even such a thing as a neuro-ophthalmologist. So how does one determine when it's time to go up to that level of specialty care? I know my dad's ophthalmologist was not familiar with LBD. I think this is probably very common that when there are visual changes, we're not able to get the same degree of help that we used to get before LBD comes into the picture from our ophthalmologists. So how do we know when's the time to look for additional help?
I'm actually going to throw that one to Samantha, because of course I would be biased in my answer, say, oh, we will see everybody. But I think it's such an important question, and I know that Dr. Holden will be able to kind of help with that question.
Yeah, and I think it's a multi-part answer, right? Because we certainly don't have enough of these experts, and there's not even enough neurologists to go around, let alone subspecialized neurologists. And I think we're so lucky here in Colorado. It's a great place to live and people want to be here. So we benefit from such a great team here. But there are a lot of places where there aren't even enough neurologists or ophthalmologists to go around, let alone combined specialists. In terms of when I send somebody to Dr. Pelak's clinic as a neurologist, whether that's with my hat on as a movement disorder specialist or as a cognitive specialist, it's when I'm trying to better define exactly where this person's problems with their visual function are coming from, and to make sure that we're getting them into the right types of treatments, where sometimes, as we've all alluded to, things overlap a lot and can make each other worse. And so the advanced examination techniques that Dr. Pelak and Dr. Van Dok can do to help disentangle those from each other and get people the right treatments. Because if I had $1 for every patient that told me, I keep going to the eye doctor, they keep giving me a new prescription, it seems okay while I'm in the clinic, and the second I get home, it doesn't work anymore. And so in those situations where we're trying to sort out what's what, that's where having that extra level of expertise, and why we're so lucky here having Dr. Pelak and Dr. Van Dok to be able to look from both sides to say, this is an eye problem, this is the brain problem, this type of device will work, this won't. And then getting people into Karen's queue to practice with those things, see what's useful for them so that they can live their lives as best they can, even with some of these symptoms. But absolutely an issue that we don't have enough of these specialists to go around. In terms of, is there like a directory for neuro-ophthalmologists, Dr. Pelak, kind of how we have the Movement Disorder Society specialists? Is there something like that?
There is. We have the North American Neuro-Ophthalmology Society, and if you go to that webpage, you will be able to find, as a person who's not a part of that program, they'll have what's called patient information, and you can figure out where the nearest neuro-ophthalmologist is to you, and that's called Nanos. And I can send that to Angela with the URL so you can get there easily. But having somebody like Dr. Holden, who is part of the LBDA RCOEs throughout the country that LBDA established, will be able to help you determine whether your next move does require a little bit further dive, and whether or not somebody like Karen will be able to make a big difference in your life. But starting with those LBDA RCOE experts can really help you with that. But definitely I can give you that URL.
Just put it in the chat.
Okay, we are unfortunately really running out of time. We had so many questions that came in, and I know we can't get to more. So we will take a look at what questions we might be able to answer and then distribute, share information through our blog and whatnot. Julia Wood is online, but she is having an unstable video connection and internet connection. But Julia, can I ask you if you want to close out or say any closing words?
Yeah, thank you so much. I'm so glad that when I got crashed, you all didn't. So thank you, Angela, for jumping in. I just wanted to let you all know, because a huge question that we get is, is this recorded? How do I get this information? You will receive an email in about a week with a link for the recording, but you can also go to our YouTube channel, and all of the recordings of all of the webinars is there. But I wanted to let you guys know about something really special that I don't think I even told Dr. Holden and Dr. Pelak about, that a resource they created many years ago that I found in the archives of LBDA. We have created a downloadable resource of that. So you'll also get the link for that resource in your follow-up email. So keep an eye out for that as well. And then just in closing too, I just want to remind you all to please look at our next webinar coming up with Dr. Jim Galvin. You can sign up for that. And actually on Monday, we have one with the International Neuropalliative Care Society. If you haven't signed up for that, please do. And with Angela, I want to do a big thank you. We're getting lots of applause and hearts for our team at University of Colorado. You guys did such an amazing, amazing job. And Angela, thank you so much for jumping in. And anything you want to add about the Research Centers of Excellence, Angela?
I will just share, this is a fantastic resource for LBD families. I wish that it existed when my dad was alive. We have over 20 academic medical centers with LBD expertise, research studies that are ongoing and looking for participants. I encourage you to go to our website, lbda.org/RCOE, and look to see if there's a center near you. We, as Julia mentioned at the top of the webinar, we are looking to expand this program in the coming year. And we hope that that will expand your access to LBD experts.
Absolutely. And with that, we'll let that be the last word. Thank you all so much for joining. We hope to see you all again. Thank you, Dr. Holden, Dr. Pelak, Dr. Van Dok, and Karen Hookstadt, and most to Angela Taylor for stepping in. Thank you so much.
Thank you to Julia. Take care, everybody.
Bye, everyone. Thank you.